All right, so we're going to talk here about fatty acid synthesis and oxidation. Now, this is a complex pathway, or two pathways really, and I'm going to go over this in a way that makes it as simple as possible. And even though when I write all of this out, it's not going to look simple, I'm going to point you towards the most important things that you need to know for the exam. Now, although step one is not a clinical exam, they like to ask you questions on the basic sciences that are relevant clinically most of the time. So what you really want to hone in on, therefore, are the pathologies, the disorders that can go wrong with each of these pathways. Okay? So let's go ahead and start. We're going to start with fatty acid synthesis. So we're making fat. So we start out with acetyl CoA and oxaloacetate. Now, right off the bat, you might be wondering, well, why are we starting with that? That's Tca cycle, right? Now, the fact is that acetyl CoA exists within the mitochondria, but it can't leave the mitochondria. And fatty acid synthesis takes place in the cytoplasm. So because acetyl-CoA cannot leave the mitochondria, we need to convert it to something that can. And that something happens to be citrate. Well, as you know, we can make citrate very easily using the enzyme citrate synthase. Okay, so this is very easy. It's one of the steps of the Tca cycle. And so it just uses citrate synthase. And now citrate can easily cross the mitochondrial membrane and enter the cytoplasm. And so that's exactly what happens. So here we have citrate now in the cytoplasm. Now citrate will then use an enzyme called ATP citrate lyase. ATP citrate lyase. And what that does is it converts the citrate back into acetyl-CoA. And of course, it's going to get rid of oxaloacetate. Okay, so you just did the reverse from citrate synthase. Now remember that citrate is 6 carbons, oxaloacetate is 4 carbons, and acetyl-CoA is 2 carbons. We'll see how this is important in a little bit. Now the next step is to add a carbon onto acetyl-CoA, and that's going to be important as we'll later see. So what we do is we add carbon dioxide onto acetyl-CoA, and we get malonyl CoA. And that's just 3 carbons. Now the enzyme that does this is super important, so please pay attention. The enzyme that does this is called Acetyl Coa Carboxylase, and it uses biotin as a cofactor. All right, now the reason that this enzyme is really important is because this is the rate-limiting step in fatty acid synthesis. Now, what is going to regulate this step? And this is something that will get asked about on the test because they like to go after, with these enzymes, they like to go after the regulators. So one of the things that induces this enzyme is citrate itself. Okay, so you have citrate in the cytoplasm. It's going to activate this enzyme. And all it's saying is, okay, we've got citrate. We need to do something with it. So as long as I'm here, we might as well make fat. And so citrate tells acetyl-CoA carboxylase to start working more. Now, another thing that does that is, of course, insulin. Now, why would insulin do that? Well, insulin is a hormone that essentially tells the body, you've got sugar, do something with it. Either make energy or store it as fat or glycogen, but just do something with all this sugar that's laying around. And so insulin is an upregulator of acetyl-CoA carboxylase. Now, what will inhibit this? Well, naturally, if insulin upregulates, then it's pretty safe to say that glucagon is going to inhibit. And that's indeed what happens. Okay? All right, so we have this malonyl CoA. And what happens is that Malonyl Coa will get added to an Acetyl Coa. Okay, so that happens like this. So Acetyl Coa, then we consider Acetyl Coa to be our primer. It's the beginning of the fatty acid synthesis. So Malonyl Coa gets added to Acetyl Coa, and then it gives off a CO2. And so as you can see, we've got a 3-carbon, we've got a 2-carbon with Acetyl Coa, and then we lose carbon dioxide, so we wind up with 4 carbons. Okay, we've got a 4-carbon molecule. And this is going to continue, and it's going to go on and on. So what happens is that we add a Malonyl Coa, and it's going to be Malonyl Coa that is our sort of building blocks. That, remember, has 3 carbons. We lose a carbon dioxide, and now we've got a 6-carbon molecule. And this will go on and on and on until we get a 16-carbon or palmitoyl-CoA molecule. And that is your end product. So you'll end up with palmitate, which is a 16-carbon fatty acid. Okay, so that is fatty acid synthesis. Important thing to know with this is that you're using the citrate shuttle. You've got to have citrate in order to cross into the cytoplasm. The major rate-limiting enzyme is acetyl CoA carboxylase, which is upregulated by citrate and insulin, inhibited by glucagon. And then we add these carbons 2 at a time, and we end up with a 16-carbon fatty acid at the very end. Okay, so now let's transition to fatty acid oxidation or degradation. Same thing. So let's say that we start out with a fatty acid. It doesn't matter what fatty acid it is. And so what we're going to first do is we're going to add a CoA onto that. And so we get what's called a fatty acyl CoA. Now, what needs to happen is that we need to add something to this. And this something is called carnitine. Carnitine is a very special, you might call it, I wouldn't call it a cofactor. It's a special molecule. And what carnitine is it's the fatty acid's ticket into the mitochondria. And it's only in the mitochondria where you can actually do this oxidation process, where you can really break down the fatty acid. So think of carnitine as sort of a ticket. So we're going to add carnitine onto our fatty acyl CoA, and we're going to get rid of that CoA for now. And so what we wind up with is a fatty acyl carnitine. Now, the enzyme that does this adding of the carnitine has a name, and it's called CPT1. You may also hear it referred to as CAT1. Doesn't really matter, but CPT1. Now, the major inhibitor of CPT1, which, by the way, is indeed the rate-limiting step of fatty acid oxidation, is Malonyl Coa. Now, Malonyl Coa makes sense as an inhibitor of this process because if we have Malonyl Coa, what it's telling us is we're doing fatty acid synthesis right now. So we don't want to be breaking things down as we're putting them together, right? That doesn't make any sense. So this Malonyl Coa is the inhibitor of this rate-limiting step. So it's really the regulator of fatty acid oxidation. And to get Malonyl Coa in the first place depends on the activity of acetyl CoA carboxylase, which itself is regulated by insulin and glucagon. Okay, so we've got that fatty acyl carnitine, and fatty acyl carnitine is then able to cross into the mitochondria. Remember what I said, it's the ticket into the mitochondria. And so what will happen then is it will encounter CPT2, which is a similar enzyme, but it kind of just does the opposite. It takes the carnitine off, and it adds a CoA. And so what we're then left with is a fatty acyl CoA. And so then at this point, what's going to happen is that you've got a complex of enzymes that are going to one by one tear off acetyl CoAs, and it's going to shorten and shorten and shorten that fatty acid all the way down to acetyl CoA, assuming that we're dealing with an even chain fatty acid. And so the very, very end product of this is going to be acetyl CoA. Now, if we had an odd chain fatty acid, that would not happen. Okay, the end product would be propionyl CoA, and that, remember, goes into that vomit pathway. Okay, so that is different. We're talking here, though, about even chain fatty acids. Okay, now in the process of breaking down a fatty acyl CoA, we're going to produce a few different things. We're going to produce NADH. We're going to produce FADH2, which, remember, those are going to go into the electron transport chain and make ATP. And then we also make acetyl CoA. With each step, we're making acetyl CoA, and then we end up with acetyl CoA at the very end. So the major enzyme that's involved, and there are multiple, but you only need to know this one enzyme. It's called Acyl Coa Dehydrogenase. And there's actually multiple of these enzymes depending on the length of the fatty acid that you're dealing with. So you have a long chain acyl CoA dehydrogenase, you have a medium chain, and then you have a short chain. So they're different enzymes depending on how long they are. All right, now the end of this is that you've got acetyl CoA, and acetyl CoA can go into two different processes. It can go into the Tca cycle, and it can go into making ketone bodies. Okay, so that is it. That's your fatty acid synthesis and fatty acid degradation. Now, there are two diseases that you need to be familiar with for the exam, and now I'm going to point to where those are. First of all, there's something called systemic primary carnitine deficiency. So I'm going to write systemic primary carnitine deficiency, and that's exactly what it sounds like. You have a deficiency of carnitine. And it actually relates to a carnitine transporter, but essentially you're peeing out all the carnitine that you're taking in, and so as a consequence, you don't have carnitine to transport these fatty acids into the mitochondria, and so you can't even start the process of fatty acid oxidation. Another place where you can have a problem, and this is a little bit more common, is with one of those acyl CoA dehydrogenases that breaks down the fatty acyl CoAs into ultimately acetyl CoA at the very end. And so it happens to be that the medium chain acyl CoA dehydrogenase, or Mcad, is the most commonly affected. And so this is called Mcad deficiency. And so the result is that we're not able to completely break down long chain fatty acids and medium chain fatty acids. And so they begin to accumulate. And the consequence of this is that we're not going to be able to successfully undergo fatty acid oxidation. And so we wind up with issues with breaking down fats. Okay, so let's go into this in more detail. So we have our two diseases here that I wrote out. And so what do you expect to happen with this? So I put down here the places where you can have these diseases. We're kind of going backwards here. But they are right here with carnitine deficiency, and then up here with Mcad deficiency. So the ultimate problem with this is that you're not going to be able to make a lot of acetyl CoAs, if any acetyl CoAs, out of your fatty acids. And so if you've got deficient acetyl CoA when you need to use fat, and so we're talking here about fasting, right? So if you're taking in sugar and you're, drinking your Capri Sun or your, Mountain Dew or whatever, you're fine. You're getting sugar in that way. You're able to make acetyl-CoA. But once you start fasting and your body moves to using fat, then you start to run into problems because you can't use that fat. And so ultimately, that acetyl-CoA will become depleted because you cannot use fats. And so the result of that is that you're going to have defective gluconeogenesis. And so that is going to cause hypoglycemia. So I'll just write that down here, hypoglycemia. Now, what else is going to happen? Well, remember that fats, breaking down fats, is our way of making ketones. Remember, going back, that acetyl-CoA can be used to make ketones. And ketones are our brain's way of getting energy when we have low levels of glucose. And so we're going to have defective hepatic ketogenesis. And this process of fatty acid oxidation primarily takes place in the liver. Okay, so we're not going to have ketogenesis. Now that's weird because normally when you have hypoglycemia, you have ketones. You're going to have ketones in your urine. But in this case, because we're not able to use fats, we're not able to generate those ketones. And so we have a hypoketotic hypoglycemia, and that's unusual. That's very unusual. It's common to have hypoglycemia, but you're going to have ketones. It's not common to have low ketones with hypoglycemia. That is very characteristic of these fatty acid oxidation disorders. So when is this going to happen? It's going to happen with fasting. Okay, if you're drinking your Mountain Dew or eating your bread, you're totally fine. But once you start relying on fats, you're going to have a severe fasting hypoglycemia. And again, this is characteristic of these fatty acid oxidation disorders. Now, what symptoms would we expect in a person with one of these disorders? Well, it's going to be related to hypoglycemia. So they're going to have nausea. They're going to have vomiting. Because they are hypoglycemic, they can have seizures, and ultimately they can go into coma and die. So this is the presentation. What's going to happen? This is going to be a child because this is a disorder of metabolism. What's going to happen is that you're going to have a child probably around 2 or 3 months. Once they, maybe even a little older, once they're not bottle feeding all the time, mom kind of lets the baby go a little bit longer, maybe at night, going 7-8 hours without waking up to feed. And they're going to wind up very, very hypoglycemic, and they're going to have nausea, seizures, vomiting, coma. This is not going to present in a neonate because they are being fed frequently. So this is going to happen when the infant starts fasting a little bit more, once you start needing to rely on fat stores. So expect this to show up in a newborn, but not in a neonate. So this is going to present within the first year of life. Okay, so how do we tell systemic primary carnitine deficiency from Mcad deficiency? I don't expect you're going to be asked this on the exam. You'll probably be given one or the other as an answer choice. But just in case, let's talk about how this could present on an exam. So with systemic primary carnitine deficiency, although it does cause this hypoketotic hypoglycemia and can present that way, it's typical that you have a different thing that presents first. And that thing is a progressive dilated cardiomyopathy. So it tends to be that that's the presenting symptom of primary carnitine deficiency, not the hypoketotic hypoglycemia, just because it's not quite as severe. Now, they can get it, but usually it shows up as a dilated cardiomyopathy. So if you have a very, very young child with heart failure and you find on echo that it's dilated cardiomyopathy, then this is something that you need to consider. Now, fortunately, with neonatal or with newborn screening, we're able to diagnose these things before it becomes a problem. But on the exam, they're probably not going to tell you that. What they'll tell you is that you've got a child with heart failure. You find that you've got dilatation of the heart, dilated cardiomyopathy, and then you get maybe the patient has a history of hypoglycemia and episodes related to that. Or they may tell you that you have a decreased level of free and total carnitine. Well, then you know what you're dealing with. I don't expect they're going to tell you about the carnitine labs because that kind of gives it away. The disorder, after all, is called primary carnitine deficiency. But that's how you would know. And so to treat this, you give carnitine supplements. If you give the patient enough carnitine, they'll be able to get by. Even though they're peeing a lot of it out, they're going to be able to get by if you give them pharmacologic levels of carnitine, not just the amount that you would rely on in your diet. Now, with Mcad deficiency, this is a little bit worse. So what goes on here is that you get fat building up in your liver because you're not able to use it. And so you get hepatic steatosis. Now, if you see a child with hepatic steatosis, if that's told to you, do not assume it's Rye syndrome, because that's the other way that you can get hepatic steatosis and liver failure in a child. Remember, that's going to be probably an older child, 6, 7, 8 years old, that has a viral illness. Mom gave him aspirin, and now he's got signs of elevated intracranial pressure and liver failure. This is going to occur in a newborn. So hepatic steatosis, and of course you're also going to have hyperammonemia. And the reason there is because the liver's not working, and so the urea cycle's not functioning correctly. There's also some thought that some of these fats that accumulate can directly inhibit the urea cycle, but just think of it as the liver's not working, so the urea cycle's not working, and you're going to have hyperammonemia. Now, one way that they could ask you about this is they could say, we took a muscle biopsy and we found increased acyl carnitines. Now, what that means is that you've got these fatty acids and they've got carnitine attached to them, but you can't really go much further, and these are accumulating. Well, you know from that then, because carnitine is present, you're not dealing with primary carnitine deficiency. You're dealing with something else. And it's only going to be Mcad deficiency. Now, in real life, there's like 20 of these fatty acid oxidation disorders, but these are the only 2 that you need to know for your exam. So the treatment for Mcad deficiency is really just preventative. We just avoid fasting. As long as you're avoiding fasting, you don't need to rely on fat stores to get your energy, and so you're not going to become hypoglycemic. So in many ways, it's kind of a similar treatment to von Gierke's disorder with the glycogen storage disease, that you just avoid the hypoglycemia by persistent eating, by giving sugars. The difference versus von Gierke's disorder is that here we're going to have low ketones, whereas with von Gierke's, it's going to be normal or high elevated ketones with the hypoglycemia. Now, in general, though, the treatment, if you ever have a patient with hypoketotic hypoglycemia, or really any hypoglycemia, is that you need to address that. So that's always the emergent treatment, and you would just give 10% dextrose for that. Okay, and that's it. So I know this was long, but if you focus on these 2 disorders, and then, of course, if you focus on that acetyl CoA carboxylase and the regulators of that, that's really important. Understand that citrate is how we shuttle acetyl CoA from the mitochondria into the cytoplasm. And then understand that carnitine is the ticket for fatty acids to get into the mitochondria. And then know these 2 disorders and where they happen, you're going to be good to go.